Okay, so I think I'm sure some more attendees will trickle in as we go, but we may as well make a start. So good evening, everyone. Thank you for watching this either live or as a recording. So I would like to introduce you to our speaker for today, Dr. Eva. I'll tell you a little bit about Eva, and then I will let the floor be hers, and she can teach us about neck of femur fractures. So Eva has completed her MBBS in India and now works in London, UK as a neurosurgery clinical fellow. She has a vast amount of experience in both orthopedics and critical care prior to this neurosurgery placement, and also is a keen academic with international publications. So I would like to present to you Dr. Eva whenever you're ready, and we're looking forward to this. So I'm going to turn myself off.
My name is Eva, and thank you for the lovely introduction. And yes, today we have a small session on neck of femur fractures. It's going to be a short session just to help you assess and treat neck of femur fractures. And yes, this is a part of our bite medicine weekly webinars. So a little bit about bite medicine for people who don't really know much about it. We've got weekly webinars as well as some question banks, and we've also got a new textbook with over 200 topics, which helps us, and it's also editable, so you can add information and contribute it to as well, and keep yourself updated with everything that's coming along. And today's aims and objectives, mainly for neck of femur fracture, is to know the appropriate questions that you have to ask when a patient presents with a neck of femur fracture, how to clinically recognize that it is a neck of femur fracture, and identify what type of neck of femur fracture that is, and what are the treatment options that are available given the type of neck of femur fracture. So a little bit about the anatomy of femur before we actually go into neck of femurs. So we've got the head, the neck, the shaft, and we've got the greater trochanter right there and the lesser trochanter right here. A bit more into the detail is the fovea, which is right over there at the head, and that's how it's connected to the acetabulum of the pelvis right there. And we've got some important muscles that are connected over the greater trochanter, like your gluteus medius and minimus, and your iliopsoas over the lesser trochanter. And this is another posterior view of the femur, and the best way to identify the femur, that it is the posterior view, is to see that the lesser trochanter is more prominent on this side, and you've also got the linea aspera along the shaft here. So roughly for all humans, we've got roughly about 3.5 to 4 centimeter long of neck, and we look into an estimated angle of 130 degrees. This degrees is quite important because we've also got a classification based on this and the fracture that we are seeing. And then yes, shaft, unfortunately you can't see the femoral condyles here, but we've got the medial and the lateral femoral condyle right there. And diving a bit more into the arterial supply of the femur, I know the diagram is quite extensive, but we're just going to look into the most important arteries that are relevant for the topic. So we've got the external iliac artery coming down from the pelvis, and as it passes the inguinal ligament over here, we know that it continues down as the femoral artery just into the femoral triangle. As it's entering, it's going to give out a deep artery of the thigh right here, which is the main arterial supply for your femur. So we've got the small perforating branches which go for the shaft. And the main thing that you'll have to remember is that there is a medial circumflex artery and a lateral circumflex artery. The lateral circumflex artery gives out the ascending and the descending, and the ascending is what we're more looking into, because the ascending anastomosis with the medial circumflex, so forming like a circular ring around the neck. So if you imagine this as your head and the neck, so you've got the medial circumflex going posteriorly and the lateral circumflex going anteriorly, forming a ring around your neck, and that's the main blood supply for your head of femur. So this would be the arterial ring, and this would be all the small tiny arteries which go into the head to supply that. So it's more of a retrograde flow of blood supply from the base of the neck to the head, which is why the neck of femur fracture is more of an urgent emergency basis, because if the retrograde flow gets cut off, then we end up getting avascular necrosis of femur. And that is why when we see a neck of femur fracture, it becomes urgent. We don't want the necrosis to set in. So as for the articular ring, we've got the medial and the lateral circumflex arteries forming the ring, and we've got the anterior, posterior, medial groups of arteries, which you don't have to dive into the details of it, but I guess it's just good to know. And one more artery is the ligamentum artery, which I told you before. We've got the fovea right here. So you've got a tiny artery that comes in like that and supplies about roughly that much of the head of femur. But again, it doesn't supply a significant amount to save the femur head in case of a fracture. Diving into the neck of femur fractures, we've got quite a few types. We're going to classify them as intracapsular and extracapsular. So the intracapsular, we've got the subcapital, which is right below the head, and then the transcervical, which is in the mid of the neck, and the basicervical, which is at the base of the neck. All of this would come under your intracapsular fractures. And then you've got your extracapsular fractures, which is the intertrochanteric. As the name suggests, it's between the greater trochanter and the lesser trochanter. And we've got we don't really follow this part trochanteric, but mostly we just see it as intertrochanteric and subtrochanteric. And yes, subtrochanteric fractures are only fractures that are less than 5 centimeters from the lesser trochanter. Anything more than 5 centimeters becomes a shaft of femur fracture. That does not necessarily mean that it's a neck of femur fracture. So your neck of femur fractures are only till 5 centimeters lower than your lesser trochanter. So again, intracapsular and extracapsular divided into subcategories. Few classifications. There are a lot of classifications for neck of femur fractures, unfortunately, but I think the ones that are most followed are the Gardner's classification and Powell's classification. They're relatively easy to remember. We've got 4 stages with Gardner's classification. So the first one is an incomplete fracture and it's completely undisplaced. The second one is a complete fracture, but it is still undisplaced. The third one is a complete fracture with minimal displacement noted. And the fourth one, obviously, it's completely fractured and completely displaced as well. We can see a few x-rays coming up. So this would be a complete fracture. As you can see, it comes all the way down with minimal dislocation noted over there. And this would also be a complete fracture with minimal dislocation over there. So you wouldn't necessarily be able to pick up grade 1 and grade 2 in an x-ray. Sometimes it can be easily missed. So sometimes a more appropriate investigation for them would be a CT. On an x-ray, you can easily pick up grade 3 and grade 4, which would be also a complete fracture, completely displaced. The other classification that we normally see is Powell's classification, which is based on a vertical orientation of the fracture line. So I unfortunately don't have an image for that. So you've got the head, you've got the neck, and you've got the shaft. So you'd have to imagine a horizontal line which goes over the head of the femur like that, and then the angle of the fracture. So if your fracture is less than 30 degrees from the horizontal imaginary line, it would be type 2. 30 to 50 would be type 1, and then type 2, and more than 50 would be type 3. Type 3 would be the most unstable one. Type 1 and type 2 are a bit okay, easily fixable, but type 3 would be quite unstable and you will definitely need to fix it, in which case. We'll have a quick clinical scenario just to help us through the history taking part and the examination part. So we've got an 80-year-old woman who had a slip and fall in her garden whilst carrying a pot of water for her flowers. She slipped backwards and she fell towards the left side, had a direct impact over her hip on the left side. She is unable to get up and walk after the fall. She is brought to ED by an ambulance in over 2 hours. A quick primary survey and a secondary survey is done. No other significant findings were noted, except, I'm guessing, some pain around the left hip. Let's keep it like that for now. So diving into the history taking from an orthopedic point of view, you don't actually necessarily have to go into too much of details. You will have to check if the fall was a low energy or a high energy one. Low energy would be something like an old man slipping and falling, like our scenario at the moment, just from a ground level. But a high energy could be something of a significant fall of more than 10 feet or something, or could be a road traffic accident, and those are mostly seen in younger patients. And that is kind of important to determine, because in case you have a low energy impact and you've got a significant fracture in a younger patient, it means that his bone quality is quite bad. So you would need further investigations to see why he had the fracture in the first place. And diving into past medical history as well, you will definitely ask all the previous comorbidities, any previous surgeries that are done, and you will have to definitely ask about cancer history, because there are plenty of patients who would have had cancer 10 years before, and they would have been lost in follow-up because they think that an operation's done, no chemo, no radio, it's all completely fine. But then a few years down the line, you would see that they would have developed mets along the femur or along the spine. So cancer should be something that we're always suspicious of when we see, especially fractures in bigger bones. And other significant past medical history like osteomalacia, Paget's disease, anything related to the bone would be of clinical significance. Personal history, definitely ask about smoking and alcohol. Smoking delays healing in a lot of ways, and it can also affect the lungs. So in which case your pre-operative assessment is going to be compromised. So you would definitely have to ask about smoking, alcohol, and any other drug relation for the patient. Social history is also very, very important in ortho, because a lot of the surgeries that we do, or the decision to even go into surgery, is based on the patient's previous mobilization status and how he's been actively going about. Like, we might even have a 90-year-old who's horse riding and golfing, or we might have a 60-year-old who can't even walk past 100 meters. So is it worth doing a bigger surgery on her would be our question. So social history and previous mobilization is significantly important for orthopedics. Drug history, mainly we need to look about antihypertensives, or if the patient is on diabetic medication, because you will have to change it the day before surgery, and blood thinners. If the patient is specifically taking warfarin or something of that, INR monitoring needs to be done. So always better to take drug history, and that also gives you a clue about the past history of the patient. So definitely drug history. Clinical examination. Weight-bearing status and gait is important, but given if the patient actually has a neck of femur fracture, he would be in so much pain that he wouldn't walk, let alone move his hips. So you wouldn't ask a patient to walk and show you. But if the patient is able to walk, then my suspicion of neck of femur fractures would definitely be decreased, unless I'm looking into an impacted fracture. Inspection wise, yes, you will see that the lower limb is externally rotated and shortened because of the muscles, like I said earlier, who have attachment over the greater trochanter and the lesser trochanter. The greater trochanter provides attachment to your gemellus superior, inferior, and all the external rotators of the hip, which are still intact. Hence, the hip gets externally rotated, and it gets shortened because of the iliopsoas that's attached to the lesser trochanter. And it is good to measure apparent length. It is good to have that habit. It is a quick measurement that you can do from your ziphisternum till the medial malleolus of your leg. and compare it with the other leg. And if you feel like it's shortened, then there is definitely something wrong with that limb. And I'm happy to answer questions at the end, unless it's a very short question. Inspection wise, you can also check for bruising, any skin abrasions, and if there is any visible deformity in the leg. That's also going to give us a clue if there is any fracture or any bleeding inside. Palpation wise, definitely yes, check for tenderness. Always check for tenderness in the groin as well, because sometimes a pubic rami fracture can go missed. So check for tenderness along the groin, and obviously any associated deformities or dislocations associated with the fractures as well can be felt with palpation. Straight leg raising test. It is something that we clinically do almost with every patient who comes with a hip pain. Helps us identify if the pain is actually from the hip or from the back. And most patients with a hip fracture wouldn't be able to raise their leg at all. They'll be in so much pain, you wouldn't want to force them to do it as well. If they're able to do it, then you'd have to quickly measure which angle they can raise it to, and you'll have to check about active and passively raising as well. Passively raising is when you do it for the patient and you see if they can exceed their active degree. And take a quick measurement of that and compare it with your normal leg as well. Internal and external rotation also has to be checked, which is basically log rolling of the leg to see if there is any pain in the groin. This helps us identify associated pubic rami fractures as well. And of course, I cannot emphasize the importance of pulses. Always check for both the pulsus dorsalis pedis and your posterior tibial artery pulsation. If any of it is compromised, check with the Doppler if you can feel the pulse. If you cannot feel the pulse, then it is an emergency. There is vascular compromise. So please make sure to involve the vascular surgeon, in which case. Axial loading is not something that we normally do, hence I put it last. It's basically pushing on the patient's heel towards his head, just pushing it to see if he can actually bear the weight of your force. And it's not just ideally tapping just to see, oh, is there any pain or not? You have to push in a lot, so much that we say the patient's head has to bob at the table end. So that's how much of pressure that you're supposed to apply and see if there's any pain on that hip. And bladder volume. This is something not a lot of patients, we do for a lot of patients, but from my personal experience, there was a patient who had a pubic rami fracture and I did not bother checking bladder volume. Then I realized that her bladder was also injured because of the pubic rami fracture. She ended up developing hematuria when we tried to put in a catheter. So yes, but I try to make sure that bladder volume is always checked because I don't want to end up missing one again. AMTS is not something that you clinically examine, but I'm not sure if you're aware of the mental assessment. This is basically just to decide if you can, what kind of surgery you can apply for the patient. If it's going to be a hemiarthroplasty or a total hip replacement, you basically decide based on your AMTS score. Okay, and investigations. These are investigations that you necessarily have to do for your diagnosis and planning of the surgery. So your routine bloods, which are mainly full blood counts, USANEs, CRPs, just to make sure that the patient doesn't have any other infections anywhere. And you can do a bit of vitamin D bone profile as well to see what the bone quality is for the patient. Then, of course, for any surgery, you need to do clotting profile and 2 group and saves. Make sure that it's all done and ready to go. ECG, chest x-rays, routine again, and radiology. So radiology is how you actually diagnose the neck of femur fracture before you even decide on the surgery or not. Radiology-wise, you have to do AP and lateral. A lot of fractures can be missed if you do only AP. So when you see the lateral view, obviously you pick it up. And one thing that you always look for in AP is Shenton's line, which I'll show you in the next slide. And CT, obviously, if in an X-ray, you cannot see a neck of femur fracture, but clinically you see that the patient has so much pain on their hip, is unable to straight leg raise, internal external rotation is painful, he's clinically presenting like a NOF, then would definitely get a CT, because X-ray can easily miss a neck of femur fracture, especially if it's an impacted fracture with minimal displacement. So a CT is a high recommendation in which case. And also in CT, you might not always pick it up in an AP view. You will have to do an axial view to actually see the fracture as well. So in this would be a good X-ray to show you Shenton's line. So Shenton's line is from this line, which goes from the pubic symphysis along this lower margin of your superior pubic rami and comes down just like that. So if you can look in a bit closer, you can see that there's a small disruption of the line over here, indicating that there is a possible fracture. So Shenton's line is something that you look for when you're trying to diagnose a neck of femur fracture. In this side, if you can see, there is no disruption of Shenton's line. It's quite continuous and quite smooth. But here you can see a small edge sticking out, which gives us a suspicion for a neck of femur fracture. So coming on to management. Like I said, neck of femur fractures or emergencies, surgery has to be done on the day or the day immediately after the fracture because of impending avascular necrosis of the head of femur, because of the retrograde blood flow from the articular ring. So you have to make sure that when you see the patient and when you know that you've got a neck of femur fracture, you instantly tell them that the possibility of you going to surgery is quite high. Please be no by mouth so that we can take you off for surgery either today or the very next day. I've seen patients who did not have surgery because of severe backlog within the first few hours, and they developed quite a lot of complications, including a longer stay in the hospital because their mobility after surgery was severely restricted. They took a longer time with physio, they took a longer time with occupational therapy, so all of it was a bit huddled up. And they also developed physical complications such as pneumonia or even pressure sores because they cannot mobilize when they have a neck of femur fracture. So, and yes, make sure that someone gives a femoral nerve block for the patient. They will be in agonizing pain. So your neck of femoral nerve block comes in as soon as you see the patient as well. Either someone from the orthopedic team or from the ED team has to give the femoral nerve block so that the patient is comfortable for transfer to the ward later. And diving into neck of femur fractures, we've got intracapsular and extracapsular, like I said. Intracapsular, you can always decide between hemiarthroplasty and total hip replacements, and extracapsular is sliding hip screws, intramedullary nailing. Few examples that we've got here. This one would be a sliding hip screw. This is the long lag screw that we've got. The main aim of the lag screw is that it slides into this slot over here. So it pulls down the head of femur and holds it in place with the neck so that healing can occur. And this is your plate with the cortical screws holding the plate in place. And this is your IM nailing. Both of these are for extracapsular, which we do not call as replacement. Obviously, it is a fixation done, which is the term that that orthopedics use. So this is a fixation, this is a fixation as well. And this is an intramedullary nailing fixation with the cortical screws, the nail that goes into the medullary space, and the lag screw that holds it in position again. If you look at the next one, you can see that the lag screw is actually out from the head of femur. This is a complication from the surgery that can happen if your lag screw is a bit more superior than it needs to be, in which case when the patient tries to bear weight, the lag screw cuts through the bone, especially in older people where the bone is very fragile, cuts through the bone and it does not do the job. It causes more periprosthetic fractures, which cause complications, which is a complication that you can get from fixing it. Next one is the intracapsular placement, which is a replacement, as you can see, and we've got a hemiarthroplasty and a total hip replacement. Obviously, the difference is that here the acetabulum is also replaced, here the acetabulum is not. We can go into further details of bipolar and unipolar placement, but I don't think that's too significantly relevant at this stage. We just need to know that we can do a hemiarthroplasty and a total hip replacement as well. And the reason, the criteria to find out which we can do for which patient is actually given in NICE guidelines. So any patient who is able to walk independently out of doors with no more using of a stick, pretty much basically saying that the patient is well enough to take care of her, go grocery shopping on her own, carry back her things, is able to live independently and does not have any significant condition or comorbidity such as diabetes or any other cancers or any other osteomalacia, osteoporosis, or any of those things, and is also able to carry out activities of daily living independently beyond 2 years. So this is something that we actually consider to determine if the patient needs a total hip replacement or a hemiarthroplasty. If you feel that a patient ticks all the boxes of these 3 points, then they're a potentially good candidate for a total hip replacement. If we feel like the patient already has significant comorbidities, might not be doing so well within the next few years, is already quite sick, is already quite bedridden, then definitely go ahead with a hemiarthroplasty. A patient might be bedridden and still develop a neck of femur fracture because of their poor bone quality. But then you would still have to do some surgeries on them to avoid the avascular necrosis that can potentially happen if you leave them be. Complications, like I said, if you don't do the surgery, avascular necrosis can come in. And if you do the surgery and if you happen to injure the articular circle ring, in an extracapsular one as well, can develop avascular necrosis. So you'd have to be quite careful with that. Then non-union, malunion, we know that quite common. Limb length discrepancy is when we use the prosthesis and it might not actually be the same size as the other limb. So the patient might have a bit of limb length discrepancy, maybe like 1 centimeter or 2 centimeter, in which case you will tell them beforehand that this is a likely possibility. And also you could always give them boots with a bit of height on the other side to make sure that it's all compensated. Blood clots, DVT and PE should always be told to the patient, and we do try our best to avoid them by giving low molecular weight heparins, enoxaparin, or dalteparin post-surgery. We usually start them 24 hours to 48 hours after the surgery, but we do weigh the risks of bleeding as well before we consider it. If the patient is on warfarin prior to surgery, then we do start warfarin after 4 to 5 days with a bridging dose of enoxaparin coming in. Nerve injury, sciatic nerve, which is posterior, is less likely to be affected, but the lateral cutaneous nerve, which goes right over the greater trochanter, is at a higher incidence of injury sometimes. Resurgery and fixation failure, like the x-ray that I showed you, that was a fixation failure. Obviously, we'd have to do a resurgery to fix it, in which case. And dislocations can happen, especially in hemiarthroplasties, because the acetabulum is not replaced. And the head of femur might not exactly fit perfectly into the acetabulum, into the native acetabulum, in which case. Okay, coming into a bit of questions at the end. So we've got the x-ray over here. What does this patient have on the left hip, on the left hip? So we've got the options here: a subcapital fracture, an intertrochanteric fracture, a basicervical fracture, subtrochanteric fracture, and unremarkable x-ray. If you look at the x-ray, and this is how it's been presented to you, you can always say, yes, it's a good AB x-ray of the pelvis. And you can see that the fracture line is roughly over there, which is just below the head. So you can say that this is a beautiful subcapital fracture right there. And if it comes to the management part, depending on what, like I said, depending on the NICE guidelines, you can decide between a hemiarthroplasty and a total hip replacement for this patient. If the patient is fit and well, got a good amount of years left in her, is able to carry out her activities really well, no other significant comorbidities, then definitely go for a total hip replacement. If not, to a hemiarthroplasty. Clinical scenario, a 72-year-old woman presents to the emergency department with severe left-sided hip pain and an inability to weight bear following a fall from standing. She has a background of breast cancer for which she is currently taking letrozole. On examination, her left hip is shortened and externally rotated. She complains of pain upon straight leg raise and axial loading. I think based on what's being presented to you, they clearly mentioned that it's shortened and externally rotated. So we're definitely looking into something of a neck of femur fracture. Your question is, which of the following statements regarding the patient's condition is correct? Internal fixation is preferred in younger patients. Surgery should be performed within 72 hours of admission. Offer 1 week of low molecular heparin postoperatively, and AP pelvis X-ray alone will confirm the diagnosis. Total arthroplasty is preferred in frail and immobile patients. So possible answers that we could be getting into. I could dive into the answers. So your correct answer would be internal fixation is preferred in younger patients. Yes, it is preferred in younger patients because their ability to heal is much faster. You don't really need to take out the entire head. But again, you need to differentiate if it's an intracapsular one or an extracapsular one. Surgery should be performed within the same day or the next day. So definitely not the right one. And low molecular weight heparin postoperatively is very much NICE guidelines say that we do have to give it at least 3 to 4 weeks, but then I've seen it very subjective to the consultants who actually prescribe it, because if the patient is doing really well by the time you send her home and is able to mobilize, then I would not continue the low molecular weight heparin, especially if they have a significant reason of bleeding as well. But it mainly depends on the mobility of the patient, in which case at the time that they're going home. And AP pelvis X-ray alone cannot differentiate it, definitely cannot confirm the diagnosis. You need a lateral view as well. And total arthroplasty is not preferred in frail and immobile patients. We would go for hemiarthroplasty in these kind of patients. And that's it. Thank you. And yes, I can take all the questions right now. Why is warfarin preferred over heparin? Warfarin is not preferred over heparin or low molecular weight heparin. I'm sorry if that was that came out wrong. We do give low molecular weight heparin, enoxaparin or dalteparin, if anything. We do not give warfarin unless the patient was already taking warfarin prior to surgery because of a heart valve issue or atrial fibrillation. Then in which case we give both at the same time, bridge the dose, monitor INR, and then stop low molecular weight heparin slowly over the days. That's when we actually involve the GP as well and make sure that INR is being constantly monitored. What does AMTS stand for? Oh, that's a good question, actually. It's abbreviated mental test score or something of that sort, if I'm not wrong. It's basically, you got a bunch of 10 questions that you ask the patient during admission, and that will let you know if the patient is oriented or not, or if he or she has any delirium or dementia. So questions basically go as, how old do you think you are? What is your date of birth? Who do you think I am? Where are you right now? What's the time right now? So basically a bunch of 10 questions that have been allocated, and you score the patient out of 10. Anything less than 6 would mean that the patient does not have capacity and hence cannot consent for the procedure. In which case you will decide between a consent form 1 and a consent form 4. So if the patient does not have the capacity, you will inform the next of kin and then go for a consent form 4. If the patient scores above 6, then he or she has capacity, you would explain the procedure to her, check all the rules of consenting, of basically informing if they have the ability to retain the information, weigh the information, and convey it back to you. You will check all of that, and then you will ask them to consent for the surgery. And yeah, explaining the risks and benefits of the surgery as well. That is basically why I mentioned AMTS in clinical examination, because most of your registrars, they will come in asking what is the AMTS score, because they would want to get the consent ready for the patient, especially if it's an emergency one. So it's better that you have your AMTS score in hand. All right, that's it then. If anybody has any other questions, please feel free to ask. If not, that's about it then. Thank you so much for attending the class.